The first speaker, without further ado, may I ask Professor Vas SADDA to talk about imaging Drusen, geographic atrophy, and Neovasular AMD. Please, Vas.
Thanks, Paisan. If I can get my talk up, or do I have to do that? Okay, fantastic. So yeah, I have a tall order to cover in 10 minutes, so I'm going to talk specifically about geographic atrophy, neovascular AMD, and not say a whole lot about Drusen, just because of the limitations of time. These are my disclosures. So let me first start with how we approach the diagnosis of geographic atrophy in 2025. A few years ago, we actually had published this report summarizing some of the advantages and disadvantages. This is not meant for reading. I just wanted to throw the reference there if someone's interested. But just want to also highlight here that flash color photography has been the gold standard for diagnosis for many decades. We have this very nice definition for atrophy in looking for sharply demarcated borders of depigmentation with increased visibility of choroidal vessels. The challenge, of course, with standard flash color photographs is that in the real world, we don't always have sufficient contrast to be able to identify the borders of atrophy. We all can tell there's atrophy in these images, but exactly where does it begin and end is really a challenge. And that's where we're fortunate that we have improvements in imaging technology in the form of confocal imaging, and then on top of that, multicolor imaging, as I'll mention. And we have shown that with confocal imaging, we can improve the contrast for identifying the borders of atrophy and actually achieve reproducibility amongst human graders, at least, for comparable to fundus autofluorescence. Now, of course, you can use white light through a confocal aperture, but of course, you can use different component wavelengths of the spectrum to require this kind of imaging. And again, this kind of confocal multicolor imaging can do very well for rendering atrophy. And of course, when you're using multiple individual lasers, you're not restricted to using RGB, and you can use infrared light as well. That certainly is deeper penetrating, can be really useful for identification of atrophy. It does look kind of strange, but again, you get very nice demarcation of the atrophy with better reproducibility for its identification. So fundus autofluorescence, though, I think has really become the recent standard in clinical trials, and it's not hard to see why, because of that same case I showed earlier where the atrophy borders may be difficult to discern, but are very readily identified as areas of decreased autofluorescence on the fundus autofluorescence imaging. And of course, this is not surprising that this has become a key outcome measure in many clinical trials. Now, there are some potential limitations of blue light autofluorescence. It can be quite uncomfortable for those of you who've been imaged with this technique. And some have questioned, even though we have ANSI standards for this technology, whether in the setting of retinal disease, whether those patients may be more susceptible to repeated blue light exposure. Fortunately, many devices now offer the option of green light autofluorescence, and this nice paper from Frank Holtz's group had highlighted how they can achieve similar measurements as you obtain with blue light autofluorescence. And more recently, we evaluated this on using ultra-wide field imaging platforms, and we demonstrated that graders can do this assessment quite reliably, although, and then the measurements are quite well correlated with standard 30-degree imaging, although I will say that they don't exactly measure the same, and don't have the time to get into the details of that. You could also use near-infrared reflectance imaging to measure atrophy. We've shown that that can also be quite reliable, and this may give us maybe useful because many of our historical OCT data sets also have a companion IR image that potentially could be used for this type of assessment. What about OCT? Well, atrophy can readily be identified on OCT. We can all see these areas where you see increased transmission of light into the choroid, and we take advantage of that signal we call hypertransmission. When we do an en-face projection image of the OCT data, it appears hyper-reflective on the en-face image. We and others have shown that this correlates quite nicely, measurements of that area of hypertransmission with OCT. But there questions came up with regards to, well, what is a threshold at which you call this hypertransmission atrophy? And it turned out we really didn't have a consensus for this definition, and so that was the underpinnings for the CAM program. Some of the CAM authors are here in the audience, but atrophy ultimately in this consensus discussion was identified as an area of hypertransmission of at least 250 microns with corresponding attenuation or loss of the RPE band, as well as some evidence of loss of the overlying photoreceptors. Now, the hypertransmission defect component of this definition, of course, is what we use, especially at en-face imaging, to measure the atrophy. So we measure the hypertransmission defect, and that can be useful to track the growth of atrophy over time. So with that as covering really a whirlwind through atrophy, I want to switch now to neovascular AMD. Historically, the gold standard for identifying macular neovascularization was dye-based angiography, fluorescein or indocyanine green. But this is sort of really the takeaway summary slide, that in 2025, fluorescein angiography is largely used for confirmation of diagnosis on certain cases and when treatment response is not as expected. ICG remains the gold standard for PCV diagnosis, but dye-based angiography overall is now largely a secondary tool in diagnosis and management, as I'll illustrate. So those of you who've been around at this for several years have seen this evolution from a shift from an FA to an OCT-based classification of lesion types. And I want to say that I think this classification is actually useful and important. When you have type 1 neovascularization below the RPE, there's evidence to suggest that it may protect against the development of atrophy if exudation could be controlled. And in particular, we have shown that those lesions can develop a neochoriocapillaris, which seems to be the substrate that is supporting the RPE and photoreceptors. On the other hand, if you have very large pigment epithelial attachments due to these type 1 lesions, that can be a negative prognostic sign, as it can increase the risk for development of an RPE tear, as we showed in this post-hoc analysis from the Hawk and Harrier trials. In addition, of course, if you have polypoidal lesions, patients may have, in some cases, a suboptimal response to anti-VEGF monotherapy, although the newer second-generation agents seem to be faring better. And I'm not going to, I suspect Dr. Vorporn is going to get into more detail on this, but of course we have some clues now of being able to recognize PCV on OCT that have been described by a few different groups now. Now, type 2 neovascularization is also important to recognize. It appears as subretinal hyperreflective material in OCT. Again, not a trivial feature to identify, as this kind of material can be associated, especially if it's thicker, with poor visual outcomes. And we showed this in the long term as well in an 8-year follow-up study. And so this is one of the reasons why we believe that aggressive treatment to eliminate SREM as early as possible is important. This is a more recent post-hoc analysis from the Hawk and Harrier trials, where you can see that in the blue curve, patients who had SREM on OCT, they still had a visual improvement, but you can see it's lower compared to patients who did not have SREM. And in fact, that was the main variable. In just about every study, when you look at variables that predict treatment response, SREM comes out. And it should surprise no one here, right? If you have material between your RP and photoreceptors, that's probably not a good thing. Finally, and I just want to say that it's also become an important biomarker as people have been developed, as many companies have now talked about targeting treatments to deal with fibrosis. And in this analysis, again, we showed a difference between brolucizumab and aflibercept, greater reduction in SREM in this post-hoc analysis of Hawk and Harrier in brolucizumab-treated eyes compared to aflibercept. Now, finally, I'll just switch to type 3 neovascularization. Again, I think that's also quite important to recognize. This is an intraretinal origin from the deep capillary plexus. These patients typically respond very well to anti-VEGF monotherapy, but virtually all of them, this study, they said 86% in my clinical experience, 100% of patients with type 3 neovascularization will go on to develop atrophy. And some individuals, for that reason, have suggested a PRN treatment approach compared to treat and extend for this subgroup of patients, although I think that still needs to be evaluated in prospective trials. So far I haven't said anything about OCT angiography. So where does it fit into the diagnostic paradigm for neovascular AMD? We certainly know that OCTA can do a brilliant job of displaying the intrinsic vasculature of these, especially type 1 and type 2 lesions. There's no question it can be quite effective in that regard. And so, I talked about the importance of identifying SREM. But SREM can be from many sources. It doesn't always have to be neovascularization. It could be the exudation, the hemorrhage associated with the neovascularization. And this is where OCT angiography can improve the specificity of structural OCT by identifying the actual intrinsic vasculature. Type 3 neovascularization can sometimes be more tricky to identify. You have to scrutinize for it, but you can identify in this example here of an area of intraretinal neovascularization that's now extended inferiorly towards the sub-RP space. Polypoidal lesions are variably seen on OCTA. That's why I say that ICG remains the gold standard. You certainly can identify inklings of them, but sometimes it's very difficult to resolve them as specific polypoidal lesions using this approach. Cases where OCT angiography can be especially useful is where dye-based angiography is difficult to interpret, like patients with chronic central serous, where there can be staining of the RP alterations that's difficult to distinguish from leakage. This was a patient with CSR who was observed, had nice resolution, but presented 11 years later with recurrent subretinal fluid. But now we could see an interesting new finding with this double layer sign. In fact, OCTA confirmed the presence of neovascularization in this case. And of course, it's important to recognize patients with early neovascularization without fluid because these patients do have an increased risk for conversion and may need to be monitored more frequently. So to summarize, atrophy can be assessed with, and measured with multimodal imaging. I think color photography or flash color is the past. The present has been blue fundus autofluorescence, but for my money, it's these newer technologies that we're going to be using going forward. Measurement and monitoring of GA has become important because we'll hear more about therapies for GA later on in this session. And dye-based angiography has largely been supplanted by OCT and OCTA, but ICG still remains the gold standard for PCV. Thanks very much.
Please.
Yeah, great talk. As usual, Vas, and welcome to the session. Something you've been working on is the choriocapillaris layer, and it's something I've also asked you earlier, is how far or how close are we to, quantifying choriocapillaris flow defects and, finding a value or a trigger towards, neovascularization onset?
Yeah, thanks for that question, Anand. I'm always afraid to answer quantitative questions with Joe Carroll in the audience, but because he's often reminded us that we really need to adjust for things like axial length to get reliable measurements. But having said that, I think our group, as well as several others, have spent a lot of time in trying to develop repeatable protocols. Maybe we're repeatedly measuring them wrong, but I can tell you that we can repeatedly measure them and then track them over time. So it can be done. You do have to have good quality imaging, and segmentation accuracy is quite important for being able to identify the choriocapillaris. But I think for my money, even though I think everyone in this audience, many people have experience with OCT angiography, use it for many reasons, for identifying non-perfusion retinal neovascularization. But for my money, the greatest contribution of OCT angiography is going to be our assessment of the choriocapillaris.